In Module 3, we're moving from the screening process into the true assessment process of looking at folks with ASD either initially or in reevaluation. So if it's an initial evaluation, obviously you've been led there by what the screening process suggested to you. And when we're going into initial evaluation, which we're going to go over during this module, but then start to focus much more on evaluation for programming. At this phase, though, of course, you're looking initially if there is a presence of ASD, which has been already indicated at the screening level. How severe that level might be because of the broad spectrum. The interventions then that would be helpful should come directly out of the data collected in the assessment. And then your means of progress monitoring should be established at this point. Again, interviews and observations are used a great deal as they were in the screening process. Here you would be looking for more structure and more norming information with these instruments, and then also move into several different types of instruments that would be utilized by a variety of professionals in order to capture the social behavior, the language and communication, adaptive behavior, motor and social skills, and the cognitive functioning of the individual. Again, this assessment process mirrors the complexity of this disability. The reason you see developmental in the approach, that term is again because regardless of the time of an initial evaluation, by definition it's believed that the core symptoms were present in the individual even in early childhood. So as I noted earlier, we are seeing this initial assessments later and later due to the broadening of the spectrum and the high functioning of some folks. But irregardless, by definition, these were developmental symptoms early on. We also know that ASD at this point is a lifelong disability, and a developmental assessment then provides a real yardstick around the severity. In other words, it gives you a sense of where the individual is functioning and the gap between that and the milestones you would expect. And it's clear from the earlier slide and all of that needs to be collected that it would be certainly done by a team. So you have many people gathering information in their area of expertise and sharing it with the entire team. Who those people are, some are listed here, there could be many others. Typically this is what we would see. The school psychologist, you may have clinical folks involved, you may have lots of outside evaluators outside the school system sharing information, obviously. For planning purposes, you'd have both the special and general educator involved, speech and language pathologists, certainly OT, and many other additional folks could be involved based on the individual who we're looking at. We know that in any case, this kind of assessment is a continuing process. And so again, it's developmental kinds of issues we're looking at, and we're working with an individual over time, and so there's no end to how much time we need to spend constantly formatively looking at the progress. The particular things, again, would depend on the student's age, the kinds of things we look at initially, and we'll get into a short slide presentation about that more specifically. You base the things you do in the assessment upon that specific individual's history, the referral questions, what brought you to this point, and any earlier data that you have from evaluations in the past. Best practice in ASD assessment for school-age children includes this laundry list of things. And again, we are going to look at assessments at different ages. But minimally, you would be looking at a record review, all kinds of medical history information that you can find, or old evaluations. We already mentioned the parent-caregiver interviews, the teacher and parent both looking at social skills in different environments. And then the cognitive academic assessments mentioned earlier, adaptive behavior. Keep in mind that the range of intellectual disability within the spectrum can be enormous, and so adaptive behavior might be very different one individual to another. and again, communication and language. So we'll look at each of these a little more specifically. When you're getting to records, you want to focus upon a very early developmental history, the earliest you can possibly get. Again, because we know that this is a disability that should be at least, I don't know, somewhat evident very early on. Again, depending on how high functioning someone is, that might be very subtle initially. Wanting to know what the current concerns are of the parents or the caregiver, and any information on past behavior. And then actual school records or any kind of clinical or medical records, and past interventions that may have been tried, irregardless of whether or not there was an initial diagnosis at this point. The parent and caregiver will have to give you the medical information, permission to see it. And then again, you want to see what's behavior been like as far back as we can find out. How have the milestones been met? Some may have been met early, others not. And the family medical history can be insightful, and there's a lot of research going on constantly with regard to that relationship with ASD. In the medical screening, you want to always clarify the visual and hearing acuity. We want to eliminate any sensory issues and some of the behaviors that can look like those behaviors characteristic of folks on the spectrum. And that's the case when assessing for many disabilities. Also looking at developmental regression. In some cases, you see young children perhaps developing quite typically and then suddenly not, and actually losing skills. That's obviously not always the case. There is also the issue around whether or not a seizure disorder accompanies an ASD, so you want to make sure that that's been evaluated in the past and you have any information with that regard. Now we're using standardized measures at this stage of assessment in order to capture lots of the things that we need to know about the child's development in the past coming from the parents or the caregiver. Again, as we mentioned in the screening phase in Module 2, there's more involved in administering these interviews or questionnaires than simply reading it and not being trained. And so particular clinicians need to be doing this work, and it's not something the parents do independently. And you want to look at that language and communication, the reciprocity in their social interactions, and if you've seen any sorts of stereotypic, repetitive, restrictive behaviors or interests, special interest areas, SIAs, we talk about under the spectrum. Those may have been at least subtly apparent early on. And so, again, those being classic ASD behaviors, you're tuning into a history around those. We know social impairments are typical, sometimes, again, subtle, sometimes really significant. So you want to look into that development in the child in both the home and school context. Those can be very different response environments as well. So the ADOS, we're going to talk about much more in Module 4 when we talk about specific assessment tools. It is the one that we hear a lot about these days and is considered best practice for many folks. Other people do what is ultimately similar to the ADOS by pulling in multiple different instruments and using them together. Lots of formal observations around ability, behavior, specific characteristics that speak to the diagnostic criteria, and then ratings of these things are coordinated in an instrument like the ADOS. Cognitive assessment, again, would be chosen by the clinical or school psychologist, the particular tool to be used. We know that the range of cognitive ability on the spectrum, again, is very broad. We definitely need to get information beyond a score, but much more into strengths of the individual in order to facilitate the planning for them. And it's typical to have an uneven profile, so though we certainly expect strengths to work towards, we'll know the skills that we need to focus upon as well. Again, this is not a typical achievement, like group achievement assessment. This is conducted individually by a school psychologist very often, or other professional, and you're looking specific to the individual you're evaluating across their learned academic strengths and weaknesses, so that we can again work towards strength. Very often you'll see here as well very much a variable profile, and so you might find strong reading and memory skills. That's not unusual in higher functioning folks, but every individual is so unique, so this needs to be carefully evaluated across all the achievement areas. Adaptive behavior obviously links to intellectual disability, and we want to know about this so that we can again focus on what needs to be accommodated or intervened or taught specifically. So it comes along all the time with a cognitive assessment, but it really helps with goal setting. We know that language and communication is a classic characteristic of difficulty for folks on the spectrum, and so the SLP may be involved here, but many others as well. Sharing information about the use of both expressive and receptive language in the social context, in the academic context, getting all the way up to pragmatics and the most difficult sorts of subtle communication issues that we often see folks on the spectrum struggle with. And then there's even more to do. You can see how complex an assessment this is because of the many issues that have to be considered. But again, what's focused upon would be determined by the particular individual you're working with. But getting to the sensory process, and we've eliminated sensory disabilities medically, but now we're looking at the unique patterns of response to environmental sensory stimuli present in the individual, which can often be very much a disruption for them in their comfort in situations and certainly in their learning. Executive functioning and intention, that decision-making process and their ability to focus is critical. Motor skills, they're typically looking at fine motor skills, but not always. In some cases, gross motor skills are noticeably affected, and there are some classic behaviors that we're aware of. The family system is important in looking at the stressors that may be in evidence and their impact upon success in working with the student. And then are there any comorbid sorts of conditions? So again, just a little more detail on each of these. Wanting to know what we can do about the environment and the sensory input in order to make that environment a more pleasant experience for the student is important. How is their planning? How are they at controlling really impulsive sorts of behaviors? Can they organize? Higher order thinking. Those are critical issues, obviously, in both academic success and social success in the classroom that we want to take a close look at. So for fine motor, you may use see someone use a VMI, a visual motor integration test. Gross motor, sometimes we see things like toe walking and other gross motor indicators that we might want to help normalize. So this evaluation is helpful in planning for work with an OT or PT or adaptive PE, many different things that we can help the student with in the school setting. And then again, but being concerned about what is the parental stress? How can we work with parents and coordinate behavior plans and interventions that we want to see continue in the home in a very positive way, and have good communication with the parents throughout this whole process. The last thing mentioned were there are coexisting behavioral or emotional problems evidenced at times, and depending upon the diagnosticians, these may be pulled out as separate diagnoses or may be considered yet additional characteristics of the syndrome itself or the spectrum itself. So, are we looking at a significant attention issue, disruptive